Hi, everyone. It's great to have you today for this webinar of the IBAA Doc SIG. We have two very special experts on spasticity in stroke that we have invited because it's a topic, spasticity, particularly in DOC, that is very dear to our hearts, and trying to treat is always difficult. So having a better understanding of how spasticity can develop and how it could be treated better is something that is central to our the development of the field. So we are very happy to have those two experts today who will talk about spasticity in acquired brain injury from research trend to imaging-based prediction. I will first introduce, it will be really two talk in one, so we are very spoiled today. We have Dr. Salvatore Facciorusso. He's a specialist in physical medicine and rehabilitation and the Policlinico Riuniti in Foggia, Italy. He holds a master's degree in technologies for innovation in rehabilitation, medicine, and care, and has collaborated with the National Research Council of Italy. His expertise lies in the management of patients with spasticity, with a specific focus on instrumental evaluation and advanced therapeutic approaches. In this webinar, he will present an updated bibliometric analysis of Botox type A research in spasticity. Dr. Stefania Spina, who is the second speaker, is a specialist in physical medicine and rehabilitation, also at the Policlinico Riuniti in Foggia, Italy. She holds a PhD in innovative science technologies for health, focusing her expertise on neurorehabilitation and spasticity management. Her research combines advanced diagnostic, with therapeutic analysis. Her recent work investigating predictive models based on lesion characteristics and the structural disconnectome in post-stroke spasticity. So without further ado, Salvatore, if you want to start, and again, I will give you 5 minutes warning in the end to have a 10-minute Q&A. If any one of you in the attendance want to ask a question, do not hesitate in the chat to write your question like that. At least I can see them and just make a selection for the end. Thank you very much. Salvatore.
Hi, thank you for this presentation. I'm Salvatore Facciorusso, as you said, from Italy. I work in Foggia. I'm expert in spasticity and movement disorder. We use botulinum toxin, but also other multimodal management for spasticity patients. So today, just like to share my screen. Just a moment. Okay. I lost the button. Okay, no. Now. Okay, can you see my screen?
Yes, we can see it. Looks good.
Okay. Today, I would like to share with you our analysis that we conducted some years ago, but we update this bibliometric analysis about the use of botulinum toxin type A in spasticity. So let's start. If I okay. For use of botulinum toxin in spasticity, the literature is large, international, and difficult to follow. So, bibliometrics can help us to to interpret the big picture. So, what can we do with bibliometrics? We can see who published most, or who gets cited most, or which country and institution lead, and which topics and the main themes can guide this topic. So just to start, some little information about what is bibliometrics. In bibliometric analysis, we can map topic structure, knowledge base, and emerging hotspot, but we cannot prove clinical effectiveness or causality or some bias about publication, because this is not a systematic review and meta-analysis, but it's just a mapping of what literature say as in a specific period of time. For this analysis, we use the size space and not AI assisted methods. Our paper about this is the role of botulinum toxin in spasticity, and we collected almost 1,500 articles, and we use, say, the size space for co-citation, collaboration, and keywords analysis. And we found in this paper about 40,000 total citation. In 2025 update, the number of publication grows to almost 2,000 publication with almost 50,000 total citation, 7,000 authors, 500 journals, and about 69 precisely different disciplines. This is the first graph that I would like to show is the publication trend from 2000 and 2025. As you can see in this slide, you in the first year, you see when the topics emerge. So after this phase, you can see the acceleration from 2007 and 2012, maybe because of the FDA, the main approbation of the FDA about botulinum toxin, and other countries that follow this approbation. And from 2017 to 2025, except for COVID years, 2021 here, we saw a stabilization, a maturation of the field. What are the main categories? As you can imagine, the rehabilitation and clinical neurologists are the first two categories. We can have also neuroscience, pediatrics, and other special categories that collect the main paper about botulinum toxin and spasticity. Just to show a particular point, critical point, the first two categories, neurology and rehabilitation, show a different growing from 20 to 2025. In the blue line, you can see the just a slight growing of the neurology in publication about this topic. But as you can see, in the orange line, the rehabilitation grow. The slope of this line is higher than the neurology. So the interest in function and in management of this kind of patient appeared increasing in the last years. The leading countries about that published most about this topic is obviously USA. Following the USA is we have Italy, Europe, mainly Europe, Italy, England, France, Germany, and so on. The authors, most productive authors. The first most productive author is Jörg Bissell with the data of updated at 2025. Sorry. After Bissell, you can see the Italian group with Santamato, Picelli, Baricic, Smania. We can see also Eskenazi, Kanowski, Francisco in the American group. If you see this timeline about most productive authors, you have three main phases. The first group on the left of the screen, you can see Wiesel, Eskenazi, Kanowski, Fedorov, the main author in the first period of the 2000 years. In the middle part of this timeline, you can see the Italian group, but also other important authors that today have a great impact on this topic. And the right part of the screen, you can see the emerging authors like Rebai, Gilles Filpetti, me and my colleague, and so on. About the most cited authors, you can see the authors in the last 25 years, and you can see names like Simpson, Wiesel, Brasher, Buanon that write the main cited publication about this topic. In the last 10 years, I want to highlight the bars of some authors that can influence the future of this topic. We can see Santamato, Picelli, Thibault, Andringa, because with the recent paper, most cited, very cited recent paper, they can influence the publication in next years. In this picture, you can see reference. On the left, the purple side of the screen, you can see the older trials, and on the right, the most recent in the yellow, with the yellow point, represented with yellow point. I would just like to show you some important publication that influenced the paper, that influenced the topic, this topic in the early years, that mainly established the efficacy. The principal problems in the first phase is to establish the efficacy in the adult, in the cerebral palsy, with the study by Coman et al. Rassier tried to define the pathophysiology of spastic paresis, and so on. We have the guideline, the first guideline 2016 is one of the most cited paper, but in 2025, this paper, as I write in the right part of the slide, is no longer considered valid. So this is the time to find the new guidelines for the use of botulinum toxin in spasticity. But this paper is very important because it is still valid to cite in our paper to confirm our use in clinical practice, especially for the off-label treatment. If you consider, for example, traumatic brain injury and also disorder of consciousness. I tried to summarize the main citation dominant themes in the last 5 years. The first theme is to define the syndrome and how to measure it. Another important theme is to find the effectiveness in adult post-stroke patients over time, and the implementation is another important theme that is most important in the recent years, in the last 5 years, because we need to find the right timing, the dosing strategies, and the multimodal treatment. And also, it's very important using pediatric and cerebral palsy patients. So another point is the analysis of the keywords. We can see in the burst analysis, the main keywords used in the first years, but also today, are the upper extremity spasticity assessment, hemiparetic patient, injection, lower limb, the generic keywords that where the publication and the research focus on. In the last part, we can, in the last years, we find the specific, the main molecules that we use, like infobotulinum toxin, botulinum toxin, or onabotulinum toxin. But you can see also keywords like traumatic brain injury, goal attainment, spinal cord injury, quality of life, because the interest moving towards the need to find the right goals, the right management for this kind of patients. Three macro domains deriving from keywords are to find the core clinical pathway, as I say, long-term care, safety, dosing, how to do after injection, the precision. Another point is the precision delivery, what you can use to find the to study better our patient, like the use of EMG guidance, the use of the particular kind of dilution of injection guide. And another macro domain is the implementation, as I say, the multidisciplinary care, goal setting, the use of guidelines, registries, medical legal topic, and so on. The cluster deriving from this analysis, the cluster is the group of the common point of the network of a specific analysis, in particular for keyword, for reference analysis. That said, as the main important hotspot and main important theme about this topic. The first one is the adult population beyond stroke. It's not the first one. One of the most important is the adult populations beyond stroke, because the post-stroke spasticity is the most studied one, but we also have increasing, growing interest in other disease like multiple sclerosis, spinal cord injury, and traumatic brain injury, and also some rare disease like hereditary spastic paraplegia. Another theme is the use of botulinum toxin in spasticity for pediatric patients. In the last year, we saw an update of guideline by Novak et al. In 2020 that define the principal guideline to use and to manage spasticity in this kind of population. After that, in the first years of study, we saw a lot of publication about the safety. Now the interest is high about the safety, but in the recent years we established the toxin safety, because we know for sure that we have about 1%, 1% of adverse events after botulinum toxin in label, and maybe also in off-label with off-label dosage. And but now the interest is about some specific protocol, like high doses protocol. As I say, the diagnostic guidance and precision medicine is another important point, because historically we use only anatomical landmarks to inject. Now we use mainly ultrasound or EMG guidance, in some cases also electrical stimulation guidance, but the main used in the recent years is the ultrasound guide, because it can improve accuracy, efficacy, and reduce complications. Another important point is the use of adjunctive and multimodal therapies, because the recent papers show that, in particular for upper limb spasticity, the use of the botulinum toxin alone is not enough to have a good improvement of the functional outcome. So it is very, very important to combine botulinum toxin with other therapy like electrical stimulation, robot-assisted therapy, and or other adjunctive therapy like extracorporeal shockwave therapy or splinting. And now some evidence is also about neuromodulation. This is another topic that emerged from this analysis. In the recent years, many studies investigate about early intervention because, like this meta-analysis of Van Tilburg et al. In 2025 show the botulinum toxin injected within 3 months reduce post-stroke spasticity. But we don't have enough evidence about the functional improving if we use botulinum toxin in this period of time. Some paper said something, but the evidence is not enough, are not enough to show to confirm this the use that the early use of botulinum toxin can improve the functional outcomes. So, just to conclude my presentation, this bibliometric analysis obviously have some limits, because volume is not the synonym of quality, because a lot of paper doesn't mean good science. We have citation bias because we tend to cite older famous paper, perhaps ignoring the newer one, and maybe the better one, we don't know. Also, another important limit is the geography inequality, because as I showed before, the main country that developed the major the higher number of publications are from USA, UK, Italy, Europe in general, but what about Africa, Southeast Asia? Because spasticity is a global problem, it's not only problem of the western part of the world. Now, what are the research gaps? What's happening now? As I showed before, the main interest in these years is around the use the botulinum toxin in clinics, in particular what protocol is better than another. For example, the timing, the dosages, what are the goal that we can use for better outcome. The precision pathways we have to use because we cannot consider botulinum toxin spasticity like one size fits all. But we have to move to personalized botulinum toxin strategy. And finally, as I said, the scaling globally, the use of this protocol, this approach to the rest of the world, and find evidence also from the other part of the world, other than US and Europe. So thank you for attention. If you have a question, maybe later.
Yes, we'll have question in the end. I think that it was really wonderful, Salvatore.
Yes.
Maybe we'll have all the question again for you after Stefania. So Stefania, if you want to start.
Yes, I leave the floor. Yes. Okay. Share.
Just to change presentation, I share my screen. My presentation is about lesion characteristic, structural disconnectome in predictive spasticity in stroke patient. This is the part of my PhD thesis. So, to start, for the next 20 minutes, I structure my talk in two parts. First, we'll define the problem, so the specific challenge in predicting and managing post-stroke spasticity. In the second part, we'll dive into the investigation, so the study, my study. We'll detail our framework and present the results of our predictive models. Finally, in part third, we'll discuss the vision, what the results mean and how they can help in our practice. So let's begin with part one and the clinical problem that we all face. This is Raffaella. We evaluated her in our clinic 12 months after she had the stroke. Despite a year of a dedicated rehabilitation, this was a reality. So we can see she had a severe spastic left hemiplegia with fixed painful contractures in her elbow, wrist, and non-functional use of the hand. Her ambulation was severely compromised. She had stiff knee gait and a fixed equinovarus foot deformity with a modified Ashworth scale 3 out of 4. So our question was, this was her outcome at 12 months, and this was her brain on day 3. Could we have predicted this trajectory 12 months before on day 3, considering brain imaging? There is not just an academic question, it's a systemic clinical problem. The American Heart Association has highlighted that the early identification of patients at risk for spasticity is a major unmet need. We know that effective treatments are available, but their impact is limited by late initiation. In fact, real-world data show a 8 to 9 month late between spasticity onset and the diagnosis or treatment of spasticity. By then, we are no longer preventing, we are reacting. So, the real challenge is identify which patients are at highest risk. So we must improve in predicting and define the risk patient profile. To be fair, we are not starting from zero. We have important clues. We know that spasticity is not anatomically random. Decades of research have associated spasticity with lesion in specific locations like the basal ganglia, thalamus, insula, and clinical white matter pathways like internal capsula, corona radiata, and corticospinal tract. We also know that the amount of damage matters. Larger lesion volume, particularly those exceeding a threshold of about 3 cubic centimeters, are highly predictive. And finally, we know that the early clinical severity, measured with scale like the NIH, is a powerful predictor. A severe initial motor deficit is a major red flag. So we do have lots of predictors. But this is not enough. We're still missing many patients. We have lots of pieces, but we don't have the full picture. We are missing the how, the why, and so maybe to open this black box, we could adopt a new paradigm. We must change our perspective. So maybe a stroke is not just a hole in the brain, it's a disconnection. It is not just destruction of tissues, but it is an interruption of network. So for over 10 years, we thought that function is written in anatomy, meaning that if you damage this spot, you lose this function. And Brodmann gave us our first cortical map with 44 cortical areas. But today, we know better. We know that function is written in connection. So the brain is a network. And in 2026, thanks to global investment and initiative like the Brain Initiative and the Human Connectome Project, we have mapped the human brain in huge detail, revealing a complex architecture of networks and regions. Now we count 108 distinct cortical areas each hemisphere. And the primary output of this global effort is the normative connectome. A normative connectome is a generalized wiring diagrams of the human brain, aggregate from hundreds of healthy individuals. Their advantage is their versatility. They can be applied to any cohort to enable network level interference and other application. And when we have a connectome, that is the map of the brain as a network, we could have a disconnectome that describes pathology as a network disruption. It is a probabilistic map of the interrupted pathways and remote effects expected from a focal lesion. And what can we do with this normative healthy connector? We can virtually damage them. And this provides a powerful solution to our research to clinic gap. So we can apply a computational approach known as virtual lesioning. Just to explain, the concept is elegant and in its simplicity. We take the one imaging we always have, the routine acute CT or MRI scan, and use the patient lesion as a digital C. So, by computationally overlaying the patient lesion into a normative connectome atlas, we can interfere the specific pattern of network from that individual patient without any additional complex scanning, and this is virtual lesioning. This is the pipeline in its essence. A lesion mask from a standard clinical scan is used to virtually lesion a set of healthy connectomes. From these, we extract brain connectivity as structural graph, or we can extract different metrics, and maybe feed into the recovery and prediction model. And so the question now is, does the specific pattern of network disconnection predict who will develop spasticity? To answer this, we established a prospective longitudinal single-center cohort study, including 28 patients with first-ever unilateral ischemic stroke. We collected high-quality imaging in the acute phase and following all the patients clinically for 12 months. We focused on three key binary outcomes at 12 months. So, functional independence measured with modified ranking scale, ambulatory independence measured through functional ablation category, and the presence of spasticity measured by modified Ashur scale. So our framework was the following. From this disconnectome, we extract a rich set of quantitative metrics First, global efficiency that reflects the system-wide impact of the stroke, so the overall network health. Second, we define a local disconnection. We measure nodal disconnection, so the percentage of streamlines cut or disconnected from a specific node, and we focus on the integrity of internal motor loop and inter-hemispheric connection. Third, we measure network asymmetry. We calculate laterality index, which quantify the imbalance in connectivity between ipsilational and contralational hemispheres, focusing on critical motor planning nodes like supplementary motor area. And fourth, we quantify lesion geometry, specifically sphericity, that is how the lesion is similar to a sphere. And the rationale is that irregular lesions are more likely to intersect a great number of tracts. So a lesion with high sphericity is a lesion with a shape really irregular. Let's turn to our result. First, for global functional outcome measured by modifier ranking scale, in the univariate analysis, the top predictors were all related, as you can see, to geometry and global topology. We calculate the power of these metrics. Try to answer the question, which single metric best predicts functional independence? And so the answer was lesion sphericity and global efficiency. In the multivariate model, combine clinical severity, as you can see here, sphericity, and motor network disconnection index, we achieved strong power with an area under curve of 0.974. Crucially, in alternative model, including only imaging, so sphericity and global efficiency, we still reach a strong prognostic value with an area under curve of 0.8. For gate recovery, the pattern shifted completely. Geometry disappeared. The top predictors were all laterality indices and disconnection of motor planning nodes. So what predicts the return of independent walking? We can see for sure supplementary motor area laterality index and motor area laterality index. In the multivariate model, we confirm this. The best model combines clinical severity with global efficiency and the supplementary motor area laterality. But finally, when we turn to our primary target, spasticity, can imaging alone predict the positive sign of spasticity? But here the answer is not so strong like the previous model. In the univariate analysis, even the best imaging predictors were weak with an area under curve below 0.6. These tell us that the lesion anatomy alone could be insufficient or not so good as in the other model to predict this complex neurophysiological situation like spasticity. However, performance improved meaningfully when we add to the model clinical severity, when we include in the model clinical severity. In fact, the best model combined the initial motor damage with the within motor disconnection, achieve an area under curve of 0.77. So for global disability and gait recovery, our model was strongly supported. We found that metric of lesion geometry and network asymmetry were powerful prediction. But when we turn to spasticity, the network level disconnection doesn't tell the whole story. So our predictive model was not so strong, was weak to moderate, and for sure could be improved. Perhaps the answer lies in other metrics we did not include in this model. So we are now reanalyzing all our data, focusing on two main actors of muscle tone, so the cortical spinal tract and the cortical reticular spinal tract. And our preliminary analysis of this tract is still ongoing, but we are observing a relationship between the integrity of the reticular spinal tract and the severity of spasticity. As you can see in this picture, in both patients have a corticospinal tract lesion at about 99%, but here the corticospinal reticulospinal tract was the difference between this patient in the case of severity or mild spasticity. So now it's time to come back to Raffaella, our initial case and our question. So we have predicted this trajectory 12 months before. Maybe the answer could be yes. So let's rewind to day 3. The Raffaella lesion volume was moderate, 3.39 cubic centimeters, so above the 3 centimeter cubic centimeter threshold, but it's not a massive lesion. The geometry of the lesion was alarming. A low sphericity and the high spatial dispersion of the lesion. So the lesion was not a compact one, it was high irregular. Topographically, the damage was not random. It was a direct hit to key regulators of tone and extrapyramidal tracts. And let's see a disconnectome map that confirms this, showing severe disconnection of the core motor nodes, as you can see in the graph on the left of the screen, the right thalamus, the right pallidum, the right caudate, and the presental gyrus. And in the video, you can see all the tracts that pass through our patient lesion, and the lesion of the patient is that, and it's difficult to see, but it's the pink one in the subcortical areas. Regarding the tracts, we see a near complete disconnection of the cortical spinal tract, 99%, but critically, a significant portion of the reticular spinal tract was spared, 28% spared. It's always probability, it's not the real tractography of the patient. So, could we ever predict this trajectory 12 months before? Maybe I can see yes. We can imagine an alternative timeline. So the prediction on day 3 based on a CT scan would have be a high critical risk in this case. So maybe our action would have been immediate entry into a spasticity surveillance protocol, which early consideration for botulinum toxin, not waiting for 12 months before an evaluation. So we should move from our current reactive model, where we wait for symptoms, to a proactive model to predict risk, to prevent. And we can propose a new clinical algorithm. So maybe starting with, of course, with clinical assessment, adding maybe the virtual lesioning starting from the standard CT or MRI scan, and maybe we can reach automated risk score generation. And in this case, high-risk patient will then enter in a specific surveillance protocol, maybe involving weekly monitoring or early consideration for focal chemodenervation. And the ultimate vision is the creation maybe of a digital twin for every acute stroke patient, with, of course, with the utility to simulate the recovery trajectories to guide maybe also other treatment like neuromodulation, and also to personalize the rehabilitation dosing with the goal to have a precision in neuro rehabilitation. Our work for sure has several strengths, like the rigorous methodology, the clinical relevance, and also the accessibility, because we use only a full open source pipeline, so cost zero, and and also the imaging was the standard imaging, not adding scan in clinical practice. But we have also important limitation: the small sample size. The first one, the indirect nature of the quantification, which rely on normative atlas, and our current focus on structural connectivity, which exclude maybe the rich information from functional plasticity. So for sure, there are lots of metric we can add to our model. But our path forward is clear. We must go for multi-centric validation on larger data sets. We need to refine our analysis to be tract specific, like the corticospinal tract and corticoreticulospinal tract. We must integrate the multimodal data, so maybe combining also structural disconnectome with resting state, functional MRI. And finally, maybe we must work towards clinical automation and maybe an AI-based one-click pipeline to generate this risk score at bedside of patient. I want to thank you for your attention.
Thank you so much, Salvatore and Stefania. That was a very good and very interesting presentation, both very different, since you really talked about a more general approach and how the field is evolving through time to treat and to study spasticity in stroke patients, and maybe the more new interest in traumatic brain injury, most likely explained by that increasing interest in rehabilitation field. There is a lot of traumatic brain injury patients too over there. And Stefania, thank you so much. I think that indeed having that more specific understanding of what lesions are associated with spasticity and how it develops is really key in better treating it. I think that maybe could you give a little, because I know in your presentation that I attended, you did give a little bit more explanation about the relation between the peripheric or the peripheral lesion and contracture that we see versus maybe something that is more peripheral nervous system and central nervous system. You talked about central nervous system, but could
Yeah.
you talk a little bit about corticospinal and this kind of mediation between spasticity and maybe this more central nervous system, um, um, I will say atrophy through time maybe and
Yes, because we know that spasticity, we have both components, the neural component and non-neural component. So I talked about the neural part of the problem, but we have lots of non-neural the component of spasticity that is for the non-use and also for the muscle modification due to spasticity. So we must consider not only central but also peripheral change due to spasticity. And this is the key point in my presentation. The reason why I want to better know the high-risk patient is also to prevent the peripheral changes due to spasticity, maybe using different kind of therapies, not only botulinum toxin, but also electrotherapy or other physical therapy. But the peripheral damage, the peripheral modification of muscle sometimes could be not reversible. So we must treat the patient early, not waiting for. And we have different instruments to treat the peripheral component. The peripheral for the non-neural modification derives from non-use, spasticity, for different reasons. And we must act on all the different reasons. Not we must go on spasticity itself, but also immobilization, also biological modification of muscle are so important. So not only central, but peripheral is really, really important to me.
Salvatore, I have a question for you from the crowd and Aurore Thibault. In the studies included in your analysis, what data are available on the repeated use of Botox? What are the main limitations associated with the use of Botox in clinical practice? And do you have experience with non-communicative patients?
Yeah, okay. Repeated, so in
Yes, yes, of
repeated,
course. So
what about the
in
what do
the
you mean about
studies,
repeated? The frequency of repeated use. What do you mean about repeated use? The many treatment in a
On
long
the
period
long
of
term,
time, or
on the long term, if you have if there is any data on like use of Botox for, I mean, repeated use of Botox in the same patients for many years.
okay, we have for our clinical ambulatory patient, we have patient since 10 years and more than 10 years. Maybe mainly part of the patient are stroke patients. We have just discontinuation in the period of COVID, and I wrote a paper about that with concerning about our patients in that period because they have to must stop the treatment and for example the worsening in quality of life and unpleasant sensation about the feeling of their limbs, of the upper limb or lower limb without botulinum toxin. They felt more heaviness, more stiffness in their limb. Obviously, with telephone interview. About the second, yes, about non-communicative patients. Yes, about this, this is an important point because especially in the early treatment, in the early use of botulinum toxin, because when you have the low level of consciousness, you cannot communicate, or for example, with aphasic patients, you cannot communicate very well. So you need to evaluate the patients, but not only with the resistance of passive movement, because you can assess the patient, you can see spasticity, but you don't need always to treat with botulinum toxin in that case. You need, in all these cases, a specific objective, okay? So, for example, if the patient can have a bad prognosis, and for example, the physiotherapist may have some difficulty because you presume that the tone come from the pain, the shoulder pain. You can treat, for example, you can try to treat muscle related to shoulder pain, for example, pectoralis major on subscapularis, and so on. But this is just an example. You don't need to treat every patient when you see increasing tone, okay? But you need a specific objective. For example, another example can be in treatment of plantar flexor spasticity. When you see, for example, clonus or hyperactivity of the plantar flexor, you don't need to treat the patient, in particular if the patients need, for example, verticalization or other training. You can treat them when you see that, for example, when you verticalize the patient, you can see, for example, equinus, so you can decide to treat the plantar flexor to reduce, to improve the equinus. So you can have many scenarios and you can adapt depending on the specific case. But about the adverse events, I think this demonstrated that the toxin is safe, and the risk of, for example, the risk of antibodies or other stuffs need to be demonstrated because also in patient that been treated in many years or with repeated treatment of botulinum toxin, we see efficacy also after 5 or 10 years.
Okay, I think that we have actually another question. I have also like another question, but that would be too much. We have 2 minutes left. I need just 1 minute to, or even less, to actually announce next webinar in June. We'll have transcranial vagus nerve stimulation presentation. So guys, if you can, please attend. We will send an email regarding those webinars. Thank you so much, Stefania and Salvatore, for that amazing presentation. There is so much that can be done based on that work, and definitely, hopefully in the future, we'll be able to help this patient a little bit better, understanding also better the mechanism and the development of that spasticity in this patient. So thank you so much, and we'll be in touch definitely to collaborate with each other.
We are available for any kind of question else in the future, or to share other information or the things about our study, about spasticity and so on.
Wonderful. Thank you so much. I just want to say, upcoming, Jennifer just posted, but I say it aloud for everyone knowing. There is the IBIS 6 Biennial, a conference on pediatric brain injury, April, May, Calgary, Alberta, Canada. And there will be a little change, of course, in the IBIA World Congress, which will be not in Spain, unfortunately, but in Halifax, Canada, in May. So usually we're in March, so it will be in May. Okay. So thank you so much again, and we'll see everyone back in June for that other topic of treatment for a patient with disorder of consciousness. Thank you so much, everyone.
Thank you very much.
Bye-bye.
Bye.
Bye. Yes.
Bye bye.
Bye.